For those of you who don't know, okay, Claire, you got the recording. We're good. Um, okay. So for those of you who don't know me, my name is Kyra, and I use she, her pronouns, and I'm the Chief Innovation Officer here at Misinformed. I'm gonna have the chat box open the whole time, and as well, like I'm gonna be watching, so like if anyone has like they want to raise hand or whatever, um, just do that, and I'll be paying attention. And I'm excited to talk to you guys today about a topic that is pretty near and dear to my heart, and that is rural health in Canada. As a health science nerd and someone who grew up in a rural community, I find rural health very interesting, and I hope that you guys do too. Um, okay. Oh, I forgot that I had a little animation. Sorry. Okay, hold on. Oh, there we go. I don't know. Sorry, guys. It wouldn't let me switch slides for a second. Um, anyway, so before we begin, I kind of just want to take a moment to share a little bit about my background. So my family's from Southern Alberta. I grew up in a family with a mom as a rural emergency nurse and my dad who runs our family farm, which I've included some pictures of here. Um, and our home is situated on the lands of the Stoney Nakoda, Sioux, Blackfoot, and Tsuut'ina nations. And I want to take a moment to just kind of pause and acknowledge and honor these communities. My family has benefited from their lands for over 100 years as grain farmers, and that's kind of ultimately granted me the privilege to get my undergrad and graduate science education and placed me in the position to speak to you guys all today. So I know it's kind of weird sometimes to do land acknowledgements over Zoom calls, but I chose to speak on this topic because I know that the challenges that my family has personally faced in accessing rural care, and I know that the communities whose land that I'm on face even more barriers than we do. So with that acknowledgement, I want to move on and kind of give you an outline of what we're going to cover today. So first of all, I want to acknowledge that rural health is a very broad and very complex topic. So we're going to have a very kind of intro, high-level overview of Canada's rural population and how we define rurality, challenges for rural healthcare patients and providers, and positive steps towards rural care. So first off, let's just talk about Canada's population in general. Canada is kind of weird and unique in the way that we have this massive geographical area, but very low density overall. And in fact, the majority of our population lives situated among the US-Canadian border. And this also happens to be where all of the the majority of the resources and infrastructure lies as well. And if we look at this map, it might be a little bit hard to see because they are very tiny, but these little green spots on the map, these little green spots represent the urban areas in Canada, and everything else is considered rural. So it's kind of funny because these areas that are considered urban make up so little of our map, but they hold about 82% of our overall population, and the other 18% is occupied within the gray space, which is almost everything in Canada. So I want everyone to kind of take a second and think about what comes to mind when you think about the word rural. Like, what do you think it means, and what kind of ideas did that drum up for you? And you can just take a moment to reflect, or you can share your thoughts in the chat if you want. Countryside, yeah. Farmlands, small communities, yeah. Yeah, poor. That's a good point. Yeah, so a lot of people are pointing to the fact that, rural communities are generally small, agricultural, low density populations, and that's all very true. Overall, though, when it comes to rurality, there's not a clear definition as to what is or what isn't considered rural. There's not a standardized definition. Different research projects and different government agencies use different definitions for different purposes. That being said, though, all these definitions usually consider three things, which are population size, population density, and distance to urban areas. So although we don't have a standard definition, we can generally say that rural communities are smaller communities, and the communities that are further from amenities and services that you'd consider be found in urban areas. And Roma's comment kind of touched on this with less infrastructure. This is things like healthcare, social assistance, education, and employment. Personally, I think the easiest way to think about this is using the rural continuum from the Rural Ontario Institute. When studies try to define rurality, they often talk about rural communities across Canada as if they're homogeneous, as if living in a small community in Nunavut has the same challenges as living in a small community in southwestern Ontario. But we just know that not to be true. Um, while there is definitely some overlap, all rural communities are going to be placed uniquely across this gradient with its own unique set of benefits and challenges. Um, so what the rural continuum takes into account is it takes into account both population densities. So the more people you have, the less rural you are, and the distance to that density. So the further away from a big city or big urban area, the more rural you're considered. And based on these factors, we can situate different communities across this gradient. And so although I'm going to be doing a high level today, I'm going to be talking about common challenges that rural communities face, but I want you to kind of keep this gradient idea in the back of your mind and think about the fact that when we're discussing different barriers that rural communities face, the more rural you are on this map would amplify essentially those barriers. So I want to take another moment to do a little reflection, and I want you guys to think about where you grew up and where you would place it along this continuum. And additionally, how you think that your geography of where you grew up impacted your experiences in healthcare, both positive and negative. So you can take a chance just for a minute to think about it. Feel free to share your answers. I'll be sharing my experience. But yeah, I'll give you guys a minute. Nafisa just pointed out a really good one, which is longer ambulance wait times. That one can be really scary. And my mom actually, when I was growing up, had a anaphylactic allergy to a bunch of different foods. And there was times when we were kids where we watched her go into anaphylactic shock and watched my dad kind of do the mental calculus of, do I drive to the hospital or do I call an ambulance and try to figure it out? I'm just reading the responses here. Yeah, and Talia, you pointed out that where you are, there's more clinics, but greater density. So I'm assuming that's on the scale a little bit more urban area. Still long wait times. We are in a healthcare shortage right now. So I think that's kind of a universal experience. Okay, awesome. There's a lot of responses. I'm not going to read through all of them, but thank you guys for being vulnerable and sharing your experiences with me. Um, yeah, okay, I'm going to move on. So I'll tell you a little bit about where I would think I would place myself. Based on the community that I grew up in, I would think I would rate it between a 3 and a 4 on this scale, somewhere in there, because I had 20 minutes away access to a small community that had a rural emergency room and primary care. But I was an hour away from Calgary where I would be able to access specialized medical and surgical care. And so really whether I was considering accessing primary care or medical or surgical care, in each case, I would need a car. Where we live, we're in the middle of essentially nowhere, in the middle of a field, as an agricultural family. And so there is no access to public transit in any capacity. And even in the small town where we would access this care, there's still not really great systems set up there. There's also no Uber. And the cab companies that do exist are very small and very unreliable. So, for my family, this was definitely a challenge, but I was lucky enough to grow up with two parents who could reliably drive. But I think about all the people in my community who, have disabilities, who have lower socioeconomic status and lower access to a car, the very young or the very old who may not have a license, and just people who don't have a license in general, and how vulnerable that must feel. Okay, so this was a nice opportunity for reflection. Thank you guys all for dropping your comments and sharing your experiences. But now I'm going to transition to talking a little bit about the challenges for both rural patients and providers of care. So first, we're going to talk about patients. And in general, rural communities are older, poorer, and sicker than urban communities. And we've already had that kind of dropped, I think, hinted at a few times in the chat already. But can anyone say why this might be, that these outcomes exist? Less access to healthcare. Yeah, that's the big one, right? There's just not as many people, not as many providers, lack of preventative care. Nafisa also pointed out a great one, that youth urbanize to get better access to jobs and education, career advancement. Yep, sicker if they have less access to care and if older. Access to culture, I think, is a really big one, especially for smaller communities, or in my experience anyways. In smaller communities in Alberta, it's been like that forever, that it's the smaller communities can be very white. Okay, these are all really good ideas. Oh, Clara, that's a good point. It's very close to my heart as well. The fact that agriculture and a lot of businesses like agriculture have folks work until they're much older. And whether this is because they want to or they have to, I think it's a very personal career to pour your energy into raising animals or crops, and they have a really hard time putting it down, in my experience. So yeah, definitely people working harder for longer. And more accidents as well, for sure. Okay, so we're going to talk about all of these kind of ideas that have been dropped in the chat, all touch on different social determinants of rural health. And there are kind of 5 main social determinants of rural health that have been outlined by the Rural Health Professions Action Plan. And I'm going to go through each of them with a few examples, and some of them that you guys have already touched on. So first off is economic status. People who live rurally have a higher risk of poverty overall. In terms of access to health services, they have difficulty recruiting health professionals and retaining health professionals. So from the medical schools, people are more likely to go into urban areas, and same with other allied health professions. They may require more travel to access care, and that's kind of what I was touching on in my experience. Less access to allied health professionals and specialists is actually a really big one, because it's really great if you are able to access care. Say you have like a surgery or something like that, and you need to access physiotherapy. It may be great that you've been able to access that surgical care, but if you don't have that follow-up in your own community, it can really be damaging overall to your progress. Community connections is a big one that determines our overall health, how well we feel connected to our communities. And rural individuals have a higher risk of living in isolation than in urban communities. In terms of education, there's less opportunities for education and career advancement. So younger people tend to urbanize, and that's true for healthcare professionals as well. And the rural environment overall just is more challenging to navigate as well. There's lack of public transport and infrastructure to help support individuals. There's higher rates of accidental injuries and deaths than in urban areas. And we kind of touched on that already, with the fact that a lot of people occupy jobs in agriculture, in oil and gas, and other trades that may be more dangerous than other jobs. There's also a higher risk of domestic and substance abuse in rural areas as well. And I want to kind of emphasize that when we think about all of these barriers are even greater for people who are Indigenous, who are immigrants and newcomers, vulnerably housed, disabled, and elderly individuals, and they're at even more risks of poor outcomes across these different social determinants. Clara, migrant workers too. That's actually a really big one, and one that I'm actually sorry that I missed, because that's a huge issue in agriculture, 100%. And I want to also say that if we think back to the rural continuum as well, as we kind of move away from the urban areas and more into the rural areas, all of these barriers can become amplified. And if he said, can you speak more to the behind increased risk of substance abuse? Yes and no. There's not a lot of like great research out there, or not a lot that I've come across. I think it might just be one of the big factors is that there's really poor mental health relatively in urban or in rural areas due to lack of mental health supports, things like isolation, like I mentioned. And so I think that that could make maybe be a big factor in that. But overall, I don't want to touch on that too much because, like I said, I haven't dove into the research, but if I can find something and send it to you after the fact. Perfect. Okay. And so when we're thinking about like who's facing even bigger barriers here, I really want to touch on Indigenous communities, because 55% of Indigenous people live in rural areas and they face additional barriers than non-Indigenous folks. So the social determinants of health and the barriers within them, they're already affecting these people who live rurally, and they're now disproportionately affecting people who are Indigenous as well. And this is through additional barriers of having insecure access to food, safe drinking water, and secure housing. So that's more likely for Indigenous communities in Canada. Additionally, lack of culturally safe care and discrimination by healthcare professionals. This is a huge one just because a lot of Indigenous folks just don't feel safe in our healthcare system, and that's a huge problem in itself. But also, it may discourage people who are Indigenous from seeking care in general. Additionally, if they're seeing discrimination in the healthcare system, then they're getting a lower standard of care than other patients as well. So this is a really big point. Additionally, in terms of community connections, there is disruption in Indigenous communities from overrepresentation in the justice system and foster care system, et cetera. And these have devastating impacts on the overall well-being of a community. And in the context of Indigenous communities, all of these things are even more amplified by the long-standing history of systemic discrimination, cultural genocide, and intergenerational traumas that leave long-lasting scars on these communities. So now that we've talked about the patient side of things, I want to flip to the other side of the coin and talk about healthcare providers in rural communities. So overall, rural healthcare practitioners are under-resourced, isolated, and burnt out. Can anyone think of why? I'll give a minute for you guys to think, or sorry, I don't know why I stumbled over my words there. I'll give a second for you guys to brainstorm in the chat and then we'll move on. Yeah, fewer providers. Fewer providers is totally a big one, because not only do they have to feel like they have pressure to accommodate more patients, but also there's less people for them to reach out to, right? Less of advanced equipment, political agenda is 100%. Lots of travel. Yeah, so tough. When there's lots of travel for patients, it's hard to kind of maintain those continuous relationships and really build upon them, especially if they're unreliably able to make appointments based on their location. Travel for practitioners as well, for sure. A lot of people who practice rurally do not want to live rurally, and so they will have to travel as well. Okay, sure. So let's kind of go through some of the points here. So first of all, rural practitioners are under-resourced due to lack of evidence-based rural healthcare planning. So what I mean by this is that typically healthcare planning is modeled off of urban programs, but they don't really always translate well to rural care. You know, they're very different communities, so there can be very different outcomes. The other thing is staff shortages. There's already a healthcare shortage in place in Canada, as we've kind of seen by all the recent emergency closures in small areas. But there's also a huge difficulty in recruiting and retaining staff to these areas, like I already mentioned before. Additionally, there's less access to allied health professionals and specialists for healthcare practitioners to collaborate with and refer their patients to. And a big one is there's limited opportunities for professional development. And this is really discouraging for people who are at the start of their careers. So at the start of their healthcare careers, they really want, if they want access to more learning opportunities, they're going to have to go to urban areas. Rural practitioners are also isolated. First of all, they have less access to peer consults. So this puts more stress on the providers to make their decisions alone rather than collaborative, a part of a bigger team. Additionally, a big one that people kind of overlook is privacy concerns in smaller communities. When you're one of the few doctors in a small town, it might be really hard for you to integrate socially because you hold privileged information. Or if you're trying to practice in a community where you grew up, it could create a really awkward dynamic for you, and it might discourage people from even wanting to live in rural communities and contribute to the issue of recruitment. Additionally, there's smaller healthcare teams overall, so just less hands on deck, more stress. And the last one is IMG placement, so international medical graduates. These are people who have completed their medical licensing in other countries and are trying to work in Canada. So sometimes they'll get placements in order for them to achieve their licensing. And a lot of the time, there's a stipulation where they have to practice in underserviced areas, which are almost always rural or remote places. But as we kind of talked about before, this can be really challenging for people who are international medical graduates because communities that are smaller might not have access to the cultural supports or religious supports, or even just socially the supports that they need in order to make that transition. Lastly, providers are burnt out. Rural providers have to wear many hats. So often in rural areas, a family physician, for example, will have their own patients, but they'll also take shifts in an emergency room, maybe a walk-in clinic on the side, and they'll even round in the long-term care homes to check on patients there too. And when you work as well in a rural emergency room, you may have to work on patients who you would normally pass off to specialist care in order to stabilize them before you could send them to an urban area. So there's a lot more pressure and a lot more decisions that are placed on individual physicians. There's also more on-call demands, having less staff. They have to work harder or work more hours. And this can be harder to maintain a good work-life balance. Less access to mental health support is also a big one. This is just true for everybody in rural areas. There's really poor access to mental health supports. But for people who are working in high stress and very emotionally charged jobs, like people in healthcare do, this can be a really big factor for them. And additionally, lastly, people who are practicing in rural communities have a higher risk of burnout. So a sad statistic that to share with you guys is that 50% of physicians are already burnt out, and rural and remote physicians are highly overrepresented in this statistic. And I want to take a second here because you're probably thinking, okay, there's 100 other healthcare professions. Why are we only talking about physicians? And I just want to highlight that this is actually a gap in the research that currently exists. There's a decent amount of literature surrounding rural physicians and rural nurses experiences, but not other professions so as much. So this is really the best that I can do is give you information about physicians and hope that in the future we'll get better information about allied health professions as well. And this is something that we're going to talk about when we talk about some more positive stuff. So one thing that I really hate about discussions of rural health is that they always tend to focus on highlighting the negatives, which I have been guilty of so far. But I think that I want to end this presentation on a little bit of a lighter note and talk about some of the positive steps that are already being made. So first off is the Rural Roadmap for Actions. This was established in 2017, and provides a framework for the pan-Canadian approach to rural healthcare planning and improved access to rural healthcare. So this is a task force that's been formed between the College of Family Physicians of Canada and the Society of Rural Physicians of Canada. And together they've established kind of four main directions on improving rural access to care. And so I'm going to take you through those four. First off is social accountability mandates. So what they're going to do is their goal is to reinforce social accountability of medical and residency programs to address health needs of rural Indigenous communities. So some things that this is going to look like is developing criteria for rural practice, strengthening policies to recruit Indigenous and rural students more effectively, and increase rural exposure to all medical students. Second thing is implementing policy interventions that align with medical education and workforce planning. And so what this looks like is establishing partnerships between government, universities, rural physicians, rural communities, regional health authorities, and Indigenous communities to together improve the medical education and increase the amount of learning opportunities that rural practitioners will have. The third focus is establishing practice models that provide rural and Indigenous communities with timely access to quality healthcare. So the key here is the word timely. Right now, they're working on developing best standards for timely transfers and appropriate consultations. So timely transfers between rural communities and urban communities in the case that somebody needs that for medical reasons, and consultations. So just getting people in rural communities to be consulted by people in urban communities more quickly. This is also going to look like developing resources, infrastructure, and networks of care within the local and regional health authorities. The other thing that they're focused on under this umbrella is working on telemedicine as well. And if you see, you have a good point that the transfers can also be harmful because this is taking people away from their community. And I know that this is specifically a problem. Well, it's a problem for anybody really, but it's a really big problem actually up north in the territories because some of the hospitals or like primary care centers will be like hours away from people's communities. Okay, so the last piece of the puzzle for the Rural Roadmap for Action is instituting a rural research agenda aimed at improving access to healthcare in rural areas. And so what this aims to do is create a rural health research network and develop standardized metrics for measuring effects of healthcare delivery so that it can continue to improve over time. So this is kind of an overmap of the rural roadmap. And now I want to kind of cover some recent advances or news that have related to goals under this roadmap. So first off is telemedicine. So telemedicine, we've all heard of it. It's basically just refers to any virtual health technologies to help deliver health services. So it's very broad. There's a lot of different cool technology under this umbrella, and I urge you to look into it because there's some pretty interesting stuff. But in general, they can be put under one of three categories. So there's either real-time e-visits, and this is like being on Zoom call with your doctor. So it'll be a live call, you're interacting. There's also remote patient monitoring. And what this looks like is having some sort of device that you as a patient would wear. So let's say a blood pressure cuff. And then from the comfort of their office, the physician could or nurse practitioner could look and monitor your blood pressure without seeing you in clinic. So that's pretty cool, especially for people who have conditions that need more long-term monitoring. And lastly, there's the asynchronous e-visit. So that is more like sending your physician or nurse practitioner information about what you're dealing with, and then they'll decide either whether you need to come in for a checkup or if you can be prescribed something or take next steps just based on sending information alone. Are there any documented difficulties with telemedicine? And yeah, so there are definitely documented difficulties with lack of access to service and internet in rural and remote areas. You'd be surprised how many communities like really just don't have strong access to internet or even phone service in Canada. It's a little bit more common than people think. I don't know of any specific examples, but once again, I'm sure I could find some if you'd like me to send them to you later. But overall, when it comes to telemedicine, telemedicine has been able to enable more connection between healthcare providers and rural patients, reduces the cost and time of traveling to healthcare for some rural patients. It facilitates peer-to-peer interactions between rural and urban care providers as well. And it decreases the number of patient transfers between rural and urban locations. So these are all like really great outcomes to come from telemedicine. But I want to make the disclaimer that it's definitely not a substitute for all healthcare. There's some things that you definitely need to have hands-on. So the physician needs or nurse practitioner needs to see you and evaluate you manually. And so this is not a substitute in that case. So when we think about telemedicine, telemedicine seems like a great example of a band-aid, but not a cure-all in this situation. There's also been some improvements towards Indigenous health in Canada. So there's been specifically improved access to culturally safe care in some areas. So first of all, almost all medical and nursing schools now offer courses on Indigenous health issues. So this is a big step because a lot of programs didn't have this at all before. However, it's not where it needs to be. Under the Truth and Reconciliation Committee, one of the recommendations was that all medical and nursing schools have mandatory Indigenous health issues or mandatory courses on Indigenous health issues. And the key word there being mandatory. While they're not mandatory right now, it is a good first step that they have all begun to offer courses and that some of the schools, such as University of Alberta, have made them mandatory. So hoping that continues going forward in the right steps. Additionally, as an Ontario example, most of the major hospitals across Ontario have full-time Indigenous patient navigators to help Indigenous patients navigate and advocate for themselves in the healthcare system. There's policies to guide the use and accessibility of some traditional ceremonies that wouldn't have been acceptable before. And Indigenous advisory committees have been established at most major hospitals that help provide direction to the staff and make sure that things are being done are culturally appropriate. Lastly, there's also improved funding for Indigenous-led research and nonprofits supporting Indigenous health. And there's actually some very positive news I saw this summer that I wanted to share, that the federal government actually gave $1.5 million to an Indigenous mental health worker team. So this organization is called the First People Wellness Circle. They're an Indigenous-led nonprofit dedicated to enhancing the lives of Indigenous communities through addressing healing, wellness, and mental wellness barriers. And overall, they're just focused on supporting better mental health for Indigenous communities. And so some of the projects, for example, that they have going on are building capacity of mental health supports through curriculum and grounded in Indigenous ways of knowing and two-eyed seeing, which is kind of the alignment of being able to see Western medicine and Indigenous traditional medicine and kind of integrate them side by side. Additionally, they're focused on fostering knowledge exchange through national gatherings, discussion panels, and they've actually created some accredited training programs for mental health professionals. And they've also established a Youth Hope Fund. So they have a $15,000 stipend granted to mental wellness teams that are targeted to support youth programs. So really nice to see other really great organizations getting funding, and we know how hard that can be. So I just wanted to take a second to highlight that. Okay, the last thing that I want to highlight on the positive note is this one's for the providers. With telemedicine, they've gotten better at being able to find connection between rural and rural providers. And so one example of this is Rural Urgent Doctors in Aid, or RUDI. And this is a 24/7 peer support line over Zoom. And it's developed for physicians and nurse practitioners in rural, remote, and Indigenous communities across British Columbia. And so what this essentially does is it gives providers quick access to peers and specialists to help support their medical decision-making process. So some of the things that you can use this line for as a practitioner is getting a second opinion on a case, reviewing a case after the fact with another provider, running through simulation scenarios, so you can use it for training reasons, navigating the healthcare system, collaboration when you're in critical times and you need to make a choice, and kind of any other situation that rural providers seem or feel necessary. And this program has actually been pretty successful in that it's prevented over 1,800 hours of diversion since 2021. And diversion is kind of what we talked about before, where patients are transferred from rural to urban centers. So obviously, there's been some things that they've been able to, I guess, eliminate the need to send out of caution to urban areas. So it's great when you think about it from a provider standpoint, but also from an overall, if we think about the overall healthcare system, it's saving a lot of money in that way as well. And there's actually a pilot program of a similar service that started in Ontario in October 2022. So we don't have any data on that yet, and there's not news yet if they've received extra funding to extend the project, but the pilot did happen. So hoping that it saw as good of outcomes as they did in BC. So this kind of marks the end of my overview today, but I wanted to just highlight some key takeaways for you guys. First of all, patients and practitioners in rural communities have unique barriers within the healthcare systems, and this disproportionately affects Indigenous communities very strongly. Second, rural communities are diverse, and interventions to improve care should be done with their community guidance. And three, great steps have been taken to improve access, but obviously always more can be done. Final note, all I wanted to say is that thank you so much for taking the time to sit and learn with me today. And I appreciate everybody's engagement in the chat. You guys have been so awesome. Also, as a final note, I realized that in my slide deck, I definitely forgot to put my references list. So I will send that into our Slack later for anyone who's interested, as well with some podcasts that I listen to that I think everyone would enjoy. But yeah, if anyone has any questions, I'd be happy to